We all kind of share this basic expectation, don't we? That, when we need healthcare, it'll just be there.
Yeah.
Accessible, high quality, tailored to us.
Right.
But the reality, well, for far too many people, it's a completely different story. There are these deep systemic health inequities,
Hmm.
which mean that ideal just isn't the lived experience for everyone. So today, we're taking a real deep dive into diversity, equity, and inclusion, DEI.
Yeah.
Specifically, how these ideas are shaping and being shaped by medicine and healthcare. Our goal here is to pull out the most important insights from, well, a whole range of sources, academic stuff, practical guides, policy talks.
Right, to give you that shortcut.
Exactly. A shortcut to really getting a handle on this vital topic.
And, this deep dive, it isn't just about listing the problems. It's about understanding the why behind them,
Okay.
exploring actual pathways forward, and also recognizing the progress that has been made. We'll lay out the basics of DEI, look at the history that got us here. We'll break down the challenges that are still very real today, and maybe most importantly, highlight actionable solutions, things that can actually foster a more equitable and inclusive healthcare system.
A complete picture then.
We hope so.
Yeah.
Something actionable for you.
Okay, let's start right there at the beginning. You mentioned those stark realities, the health disparities. It sounds like DEI isn't just like a nice idea. It's a practical necessity in healthcare today.
Oh, absolutely. A necessity.
Yeah.
The foundation here really is that health is a basic human right. Full stop.
Right.
Yet we see this really troubling pattern where marginalized groups consistently have poorer health outcomes, mental and physical, compared to the general population.
And that's not just chance.
No, not at all. It's directly linked to systemic health inequities. And these are largely driven by what we call social determinants of health.
Okay.
Things like where you live, your job, your economic situation, education, all that stuff.
Mhm.
And it creates this causal loop, often a really vicious one. Well, existing disadvantage leads to poor health. And then, unfortunately, poor health makes that disadvantage even worse. It feeds on itself. And the sources we looked at, they really bring this to life with some pretty stark examples like racial discrepancies in treatment. They stick around even when you control for income or insurance.
Wow. So it's not just about getting care.
Exactly. It's about the quality and the type of care you receive once you're in the door. And we also see patients putting off really needed treatment
Why would they do that?
because they've maybe experienced cultural insensitivity before, or they anticipate it, or they're afraid they'll get worse care, or they just flat out believe they've been treated unfairly because of their race or ethnicity.
Imagine feeling that fear when you're already sick.
Right. And then you add in things like cultural and language differences between patients and providers that often leads to serious miscommunication.
Which breeds distrust, I imagine.
Absolutely. Distrust, feeling disempowered, and unsurprisingly, really poor patient satisfaction.
And what this means for you, listening right now, is, well, it's huge. These gaps directly hit patient satisfaction, sure, but they also undermine the actual quality and effectiveness of the treatment itself.
Yeah.
If care isn't inclusive, if it isn't equitable, it's just less effective. Patients don't get the outcomes they should.
And that brings us right to these core ideas meant to tackle these problems. Cultural competency and implicit bias. Understanding these is just fundamental if we want to improve healthcare quality for everyone.
Okay, let's unpack those terms then. Cultural competency in medicine. What are we really talking about there? Sounds quite broad.
It is broad, yeah, but it's essential. Basically, cultural competency is the combined ability, whether it's a whole system, an organization, or just one specialist, to work successfully across different cultural contexts.
Okay, and culture itself means?
Think of culture as those integrated patterns of human behavior. The language, ideas, actions, and beliefs, customs, everything that defines different ethnic, social, racial, or religious groups. And competence is simply the ability to operate effectively within those diverse customs and beliefs and needs that patients in their communities have.
And this isn't a brand new concept.
No, not at all. The term itself goes back to 1989, Cross coined it, and since then, different models have popped up. Like Campina Bacote in 2002 broke it down into things like cultural knowledge, awareness, skills. Leininger, also around then, really focused on understanding different health beliefs, values, even religion.
Okay, so that's cultural competency, the goal, kind of. But then you mentioned implicit bias. We hear that term a lot. How does that fit in? Is it related or something separate?
They're definitely distinct, but they're deeply intertwined, critically intertwined. Implicit bias. These are the judgments or behaviors that happen, like below the surface, below conscious awareness.
So you don't even know you're doing it.
Often, no, it's without intention, without effort, sometimes without control. And the key thing here, the sources emphasize, is that these biases are omnipresent. We all have them.
Including doctors and nurses.
Including healthcare providers, yes. And they play this significant, often invisible role in keeping health disparities going because they can subtly nudge clinical decisions and ultimately affect patient outcomes. So see, while cultural competence is the big goal, providing effective, respectful care across cultures, these implicit biases can seriously get in the way.
Right. They can undermine the effort.
Exactly. So being aware of them and actively trying to mitigate them is, well, it's a crucial step towards genuine cultural competence.
That sounds like a really fundamental challenge, then. If these biases are everywhere, what's happening in medical education? How are we training future doctors and nurses to, counter these biases and become more culturally competent?
Yeah, it's definitely an evolving area, and there's a real push to integrate this stuff better. We are seeing positive steps. For instance, the National Medical Council in India actually made cultural competence a required subject in their new curriculum back in 2019.
Okay, that's significant.
It is. It's a clear signal of its importance, trying to get medical students ready to interact effectively with diverse patients right from the start. But the reality globally is that formal training is still pretty undeveloped and uneven.
So it's patchy.
Yeah, patchy is a good word. A lot of it is still learned informally, just through experience on the wards, which isn't really ideal.
No.
The sources we looked at really recommend shifting towards more interactive methods. Things like self-reflective journaling, using standardized patients and training scenarios, role-playing.
Or hands-on stuff.
Exactly, to build actual practical skills. And the big push is to weave this into clinical training, not just have it as a one-off lecture or seminar.
Right, make it part of the daily learning.
Yeah.
But what about training specifically on implicit bias? Is that actually changing behavior? Is it making a difference where it really matters with patients?
That's the million-dollar question, isn't it? And honestly, the evidence is, well, it's complicated. A big review of these training programs found huge variation in how they're designed, how they're run, how they're measured. And here's the crucial part the review highlighted. Most studies only report on, like, the lower-level outcomes.
Meaning?
Meaning they might tell you if the trainees liked the session or if they felt they learned something. But did it actually change how they behaved with patients later on?
The practical application?
Yes. Did it lead to better care? Better patient outcomes? Those are the really important questions, and often that data is missing.
What about tools like the implicit association test, the IAT? Isn't that used a lot?
It is used a lot, yeah. But its role is maybe more complex than people think. It can be really effective as a kind of disorienting experience. It's something that makes you stop and think, maybe I do have some biases I wasn't aware of.
So more for self-reflection.
Exactly. More for triggering that self-reflection than as a reliable way to measure if someone's bias has actually changed because of the training. It has limitations in terms of validity for that purpose.
So we need better ways to measure impact.
Definitely. There's a real need for better assessment tools to see if this training translates into real-world changes in care.
Okay, shifting gears slightly, but still related. Given all these complexities, what about the ethics of diversity in medical research, especially globally? How do we make sure research is fair when it involves different cultures, sometimes vulnerable groups?
That's a really, really important piece of this. There's a strong ethical case, an imperative, really, for promoting diverse participation in clinical research.
Why is that so critical?
Well, think about it. If the research for a new drug or treatment doesn't include the kinds of people who actually have the disease,
then the results might not apply to them.
exactly, the findings might not be generalizable or even relevant to everyone who needs help. And while, in the U.S. and Europe, the focus is often on race and ethnicity, it's crucial to remember diversity is much broader and looks different around the world. Factors like poverty, living in a rural area, gender identity, LGBTQIA+ status, these are all hugely relevant.
Context matters.
Hugely. And there's a real risk, especially in lower resource settings, that people might be recruited for studies just because it's convenient or cheaper.
Which can lead to exploitation.
Sadly, yes.
Yeah.
So ethics committees have a massive job here. They need to scrutinize studies to ensure social justice.
Right.
Like asking, who actually benefits from this research? Will the community involved get access to the treatment later?
Right.
They also have to protect vulnerable groups. Older adults, kids, people struggling economically, undocumented immigrants, LGBTQIA+ individuals, people with disabilities, and address privacy concerns.
What about paying participants? Is that okay?
Yes, and that's an important point. Fair payment isn't seen as undue inducement or coercion. It's actually seen as a way to reduce barriers, to make it possible for people who might otherwise not be able to afford to participate to actually take part. It's about fairness.
Okay, so we've established the need, the challenges, the ethical considerations. Let's get practical now. How can healthcare professionals and the institutions they work in actually do DEI? Turn these ideas into concrete action.
Right, moving from theory to practice.
Yeah.
One really helpful resource highlighted in the materials is a guide called The 12 Tips. It was put together by experts who themselves have diverse lived experiences.
Okay.
And it's built on these core ideas: diversity, equity, inclusion, intersectionality, and something called a strength-based approach. We can kind of distill these tips into some key actions.
Let's hear them. What can individuals do?
Okay, for individual doctors, nurses, therapists, one big one is beware of assumptions and stereotypes. Don't lump patients into groups. Actively recognize that your own unconscious biases will shape how you see people.
Constant vigilance, almost.
In a way, yes. Another is use inclusive language. This is more than just politeness. Respect how people identify themselves. Use terms like wheelchair user, not wheelchair bound. Be open to evolving language, like maybe using chest feed instead of only breastfeed.
What about things like person with autism versus autistic person?
Great question. That's the person first versus identity first debate. The best advice, just ask the person what they prefer. Simple as that.
Makes sense. What else?
Adopt a strength-based approach. This means consciously looking for and focusing on patients' strengths, their resilience, their knowledge, their abilities, instead of only seeing their problems or deficits.
Like focusing on strong stories for First Nations people you mentioned.
Exactly that. And maybe the most vital one for individuals: commit to self-education continuously. Inclusivity isn't a destination you arrive at. It's an ongoing process.
Lifelong learning.
Totally. It means actively learning, seeking out connections with diverse groups, and regularly, honestly, reflecting on your own biases and assumptions.
Those are powerful actions for individuals. But you mentioned institutions earlier. What about the bigger picture? Systemic changes.
Right, because individual actions are crucial, but they need supportive systems. So for hospitals, clinics, health systems, a key principle is ensuring inclusivity in the physical space.
More than just ramps.
Oh yeah. Wide doorways for motorized wheelchairs? Sure. But also furniture for different body sizes, quiet rooms for prayer or reflection, culturally relevant spaces like, say, yarning circles in some contexts.
Okay.
Another big one, ensure appropriate communication. This means using trained professional interpreters, not relying on family members who might be stressed or have their own agendas. Using multi-language signs, tools, websites.
Makes sense.
Institutions also need to ensure inclusivity in their own research. Get communities involved early when designing studies. Translate materials. Offer remote options so people don't have to travel.
Reducing barriers again.
Exactly. And think about expanding how healthcare is delivered. Maybe offer after-hours clinics, walk-in options, provide more holistic, integrated care, especially for marginalized groups, like people experiencing homelessness, addressing their social needs alongside their medical ones.
That sounds like a big shift.
It is. And it connects to another point. Advocate for a more inclusive system overall. Healthcare workers can push for better coordination between health services and social services. They can be that trusted bridge for people trying to navigate these really complex systems.
And finally,
Finally, it all comes down to building commitment, both individual and institutional. You absolutely need leadership buy-in. Organizations need diverse staff at all levels. They need to actively encourage participation from underrepresented groups, have zero tolerance for discrimination or non-inclusive behavior. And this is key. Regularly ask for feedback from all the different groups they serve.
continuous improvement loop.
Precisely. It's about always learning and adapting.
This really drives home the point that it's not just about being nice individually. It's about fundamentally changing structures and cultures within healthcare. And to really get the scale of this, maybe it helps to look back a bit. How did DEI even become such a focus in medicine? What's the history?
Yeah, looking back is useful. In the U.S. context, at least, you can see this steady expansion over decades. It really kicked off with the Civil Rights Movement.
Right, in the 60s.
Exactly. The Civil Rights Act of 1964, affirmative action policies like Executive Order 11246 a year later, these were initially focused on tackling racial injustice, trying to correct historical wrongs.
And they weren't always smooth sailing.
Oh, definitely not. There were controversies, legal battles like the Big Bake Supreme Court case in '78 about university admissions, but they set precedents. Then the focus broadened.
How so?
The Equal Employment Opportunity Commission, the EEOC, started in '65, and the women's rights movement gained momentum. Think the Equal Pay Act in '63, Title IX for education in '72. So the conversation expanded from race to include gender equality.
And it kept expanding.
It did. More recently, you see the inclusion of LGBTQ+ rights, highlighted by the Obergefell Supreme Court decision on marriage equality in 2015. And rights for people with disabilities, significantly boosted by the Americans with Disabilities Act, the ADA, in 1990. It's been this gradual, sometimes hard-fought widening of the circle. And connecting this history to the present, it's really important to bring in the concept of intersectionality.
Right, Kimberly Crenshaw's idea.
Exactly. It explains how our different identities, race, gender, class, disability status, sexual orientation, and so on, don't exist separately. They intersect. They combine to create unique experiences of discrimination or sometimes privilege.
So DEI efforts need to see the whole person.
Precisely. They have to account for that complexity, not just address one identity at a time. But, despite all this history, all these efforts, significant gaps definitely remain.
Why is that?
Well, lots of reasons. Sometimes it's a lack of real accountability. Sometimes it's just performativity organizations doing things to look good without real substance.
Ticking boxes.
Right. There's resistance, often underfunding for DEI initiatives, and sometimes a lack of psychological safety within organizations for people to even speak up about issues. Moving from just having policies on paper to having equity be the actual lived experience for everyone.
Yeah.
That's still a long road, but a necessary one.
Wow. Okay, so we've really covered a lot of ground in this deep dive. We looked at why diversity, equity, and inclusion are absolutely critical in healthcare. We defined key ideas like cultural competency and implicit bias. We examined how these are being taught or maybe not taught effectively enough yet in medical education and research. And we outlined some really concrete, practical steps for both individuals and institutions. And hopefully this knowledge helps you, the listener, better understand the healthcare world around you and maybe feel empowered to contribute to making it more equitable, whether you work in healthcare, use healthcare services, or are just an engaged member of society.
And it's fascinating, isn't it? This pursuit of real equity and inclusion. It's not like a project you finish. There's no final checklist. It's an ongoing commitment, something that has to keep adapting.
Right.
It's fundamentally about cultivating deep empathy, constantly questioning our own assumptions, and actively building systems that are designed from the ground up to ensure fairness and respect for every single person. Recognizing that ultimately the incredible diversity of human experience is probably medicine's greatest strength.
So here's a final thought to leave you with. As you go back into your day, how might this refreshed understanding of diversity, equity, and inclusion actually influence your own interactions? Or maybe even how you look at the systems and structures around you? What's one small intentional step you could take, maybe even today, to help foster a more inclusive environment right where you are? Thanks for diving deep with us.